Good afternoon, everybody. Welcome to the lunchtime symposium sponsored by Sedana Medical. The title of the symposium, just to make sure everybody's in the right room, is Inhalation, Sedation in the ICU, from Proven Therapy to Approved Standard of Care. And we have quite a nice panel with us here today, experts in the field who've been using this device in the ICU for many years. To my mind, as an American where we don't have this available, this is one of the most exciting developments in intensive care in the last few years. The ability not only to change the paradigm on sedation, but as we'll hear, also to achieve perhaps organ protection at the same time through the use of inhaled anesthetics. So I'm going to keep us on time. Each speaker will have about 17 minutes to speak. We'll leave 10 minutes at the end for questions. So our first speaker is Dr. Richard Knafe from the University Clinical Center in Ljubljana. He'll be speaking to us on volatile anesthetic sedation via the anaconda, how it works and why.
Dear ladies and gentlemen, good afternoon. Welcome to the Sedana Symposium about volatile sedation. So, Ljubljana Medical Center started using volatile sedation since now almost 10 years. We started in 2009, and duration of our patient under the sevoflurane sedation via anaconda was from 1 day to even 42 days in the ECMO patients. We treated fairly lots of patients. As you can see, there's more than 2,000 patients in our registry. So why we decided to go to sedation via inhalation anesthetics? Well, first of all, it's really easy to monitor. It's quick start, quick emerge. There are no active metabolites whatsoever. There are no interactions, and it can be really easily monitored during the use. There's a quick emergence, and especially in post-resuscitational patient, you can have quick neurological assessment. And of course, not to forget, there are really nicely decreased costs that you'll see later on. Of importance, there is no tolerance development, so it's, as you'll see later, it's perfect drug for patients that are IV drug abusers or patients who have been previously sedated for prolonged periods of time, but especially benzos. You need to know that in the use of volatiles, there's huge things going on regulatory-wise. As for now, local guidelines recommend inhaled anesthetics. However, it is not widely accepted across the world due to regulatory challenges. We have enormous data back from the 80s when it was used for children with asthmatic status. And you see here also publications in recent year with use in prolonged sedation. You have good data on using it in post-resuscitational patients with some organ protection properties. And I really advise you to check into this paper. It's from Angela Jarrett. It's an amazing paper that will give you all the data you need to know. So what do you need to perform a good inhalational sedation in your ICU patient? Well, first of all, of course, you need a ventilator, you need an anaconda device, syringe with volatile anesthetic, and then you need a device that monitors the level of inhaled sedation, and you need a scavenging system. So let's check first anaconda. You have two devices available, the standard 95 mils and the small baby anaconda of 50 something mils, which reduces the dead space with basically the same performance. What is anaconda? It's shortened for anesthesia conserving device, and as you can see, it has many features packed in small volume. So basically, it's HMI filter. It serves as a vaporizer for volatile anesthetic. You can use isoflurane or sevoflurane only. And it's a reflecting device. So upon exhalation, more than 90% of the volatile will be conserved within the filter. You need special syringes with non-lure adapter, so there's no possibility of attaching it to anything. Not to the feeding tube, not to the CV line, not to the epidural catheter, the Foley. You cannot put it anywhere except on the dedicated Anaconda system. You need a pump, and then you measure it mainstream, or you measure concentration side stream with the equipment already well available and well established on the market. You simply connect it after the Y piece to the endotracheal tube, and basically you have it all. How does it work? Well, on the start of inspiration, as I can show you here, the fresh gas from the ventilator enters the Anaconda, the volatile comes via the syringe pump, it evaporates, goes into the patient. Upon exhalation, the gases come out, go through the filter. 95% of volatile, 90 to 95, stays within the reflective media. So when the new inspiration begins, you had the mixture of new volatile and volatile that's inside the Anaconda already. Alongside with that, you also have heat and moisture exchanger of the modality of the device. How to administer it within the therapeutic range. Usually you need 5 to 7, 2 to 7 mils. You can use a normogram that are established. If you use isoflurane, you need a little bit less. If you use sevoflurane, you need a little bit more. And you can use basically whatever ventilator you want to use. There's a ventilator on the market that now enables automatic compensation for the minimal resistant and dead space. This is Löwenstein ELISA 800 that when activated can adapt for the both of the Anaconda, small and little one, and then you simply activate it. How it works. Here you can see it, how it works in the real patient. And of course you need scavenging system that can be fluor absorb. This one is enough to contain for 10 syringes, so with every syringe use, you simply mark it with a pen, and after 10 syringes you discard it according to your local policy. And if you use Hamilton ventilator or Mackay, they offer some special devices that enable central scavenging system via the vacuum pumps you already have installed in your ICU. In case of the dead space problems, you can simply insert it into the inspiratory limb and then go through the humidification system. Otherwise, you're not supposed to use humidification because you will just have the water trapped in. And if you need nitric oxide or inhalation for asthmatic patient, for example, you always must put it after the Anaconda. And here, as you can see, we put it in the inspiratory limb after the Anaconda because Anaconda will contain all the vaporized or micro dispersed inhalatory agent. In case you're using nitric oxide, be aware that Anaconda will scavenge up to 80%, so you need to measure your NO after the Anaconda and then set it accordingly. There's also some innovative use in patients with VV ECMO. Dr. Arash Pirat is using it so that simply introduces the Anaconda into the flush gases of the veno-venous ECMO. And what is of really importance, there's some good data on post-sedation effects. There's no data on delirium. In our experience, the data is not published yet. We haven't seen overt delirium with those patients, but we have good data. There is less hallucination, there's no difference in agitation or memory tests up to 6 months post-use, post-exposure to prolonged more than 7 days of sevoflurane. The cost in our country, it's cheaper to use sevoflurane than propofol, and so it's another European country. This is from Respiratory and Critical Care Medicine paper in a couple of ICUs in France and in Germany. And mind that in those costs, the duration of ICU stay, which is shorter, was not taken into account. You can use it over the spectrum of really different patients. Basically, there is only patients that have known allergy or known hyperthermic reaction to volatiles that are not supposed to be sedated with volatiles. And you can use it across the population. This is, again, off-label use, but we have our pediatrician that are using volatiles in patients that have prolonged time of ventilation. And then, of course, due to the dead space, it's always implemented into the inspiratory limb of the ventilator. You can use all the modes: controlled, assisted, spontaneous. We use it predominantly in the PAF plus in our spontaneously breathing patient, and also in pressure or volume modes. Bear in mind that if you put it after the Y piece, so between Y piece and the intratracheal tube, you need to take into account dead space, so the volumes need to be set accordingly. So take-home messages would be: it's easy to monitor, it offers really quick emergence and really quick induction. It actually takes really couple of breaths. It's superior to propofol and benzos, hemodynamically wise, pharmacokinetically, dynamically, and economically wise. It's safe, it's user-friendly, patient-friendly. You can use it for short-term, long-term, peri-procedural, even in non-invasive ventilation for bronchoscopy, for example. And you can co-administer the drugs that are needed, like if you use inhalation antibiotics, nitric oxide, or beta agonist. So if you need any have further question, feel free to visit us at the booth or check internet with really lots of user-friendly data. Thank you very much.
Thank you. Since you were so good at staying on time, we'll actually see if there are any questions specifically on the use as a sedative agent. Yes? So I'll just repeat the question so everybody can hear. Where the question is regarding the hemodynamic effects of the inhaled anesthetics. Do we see a drop in blood pressure similar to what we often see in the operating room?
Thank you for the question. The hemodynamic effects of sevoflurane, which we are using, is predictable. So it goes, the more you use it, the more the blood pressure would fall. But this is something that we would see also in propofol or any other sedative agents. We, at the beginning, I work in the medical ICU, so the anesthesiologist warned us, all about those substance A and I don't know what, and the possibility of malignant hyperthermia. In more than 2,000 patients, there was not one single case of malignant hyperthermia. We did not have any organ failure. It was interesting that just in one patient with severe pancreatitis, we had during the sedation vomiting. So when we stopped sevoflurane, the vomiting stopped, and then we reintroduced it and the vomiting became apparent again. So this is one of more than 2,000 patients. This is maybe something interesting to note, but no, there was no severe side effects, and the drop in pressure is transient.
Okay. Any other questions? If not, I'll ask one. So in the operating room, when people are emerging from general anesthesia under inhalational anesthetics, they often go through a stage of agitation. Do you see that in patients sedated in the ICU?
Sometimes we do, and lots of time we see them shiver, which is one of the side effects because it blunts the temperature regulatory in the brain, which is then again used in patients that we put under hypothermia in post-cardiac arrest. But those excitation that they would be lost or really agitated or in delirium, we have not seen it. We've seen this in benzos era. We are now proud to be the benzodiazepine-free ICU. That I like to mention whenever I have the case into the possibility.
Excellent. Thank you very much.
Thank you.
Okay, our next speaker is Professor Franz Kiel, Chairman of the Department of Anesthesia and Intensive Care at Karlsruhe. He'll be speaking about volatile anesthetic sedation and organ protection. Is that fact or fiction?
Well, thank you very much, dear Chairman. Dear ladies and gentlemen, thank you very much for inviting me to talk about my research topic, which I'm really happy to be able to present now in the next 15 minutes. A area of research which comprises more than 1,000 papers and which is going on for now 20 years in the meantime. So within the next 15 minutes, I can only give you some highlights of it. If you are interested into the mechanisms of it, I highly recommend to read this review, which I published in 2015. They're actually everything about organ protection against ischemic injury to the heart is actually explicated there. So when it all started was in 1998 that this phenomenon was actually discovered and termed anesthetic-induced preconditioning. Which led to really a hype in the field, because now, besides of having good pharmacokinetics, we also have a side effect of anesthesia that actually confers cardioprotection. And the paradigm of preconditioning is depicted here. It's of course experimental. So you do a coronary artery occlusion and 3 hours of reperfusion, and then after that time you actually take the heart and evaluate histologically the infarct size. And what is so interesting about this whole phenomenon is that if you give 15 minutes, 5 minutes, 15, 13 minutes of volatile anesthetics before you induce myocardial ischemia, you actually reduce infarct size by half or more. So 50 to 60 to 70% infarct size reduction just by giving volatile anesthetics beforehand. And just to give you an example how that looks like, you see on the left-hand side a coronary slice of the heart, and all this white area here is a myocardial infarction. 15 minutes in this case of desflurane actually virtually eliminates myocardial infarct. So there actually you have a phenomenon which you can actually use in clinical practice to minimize ischemic injury to the heart. And in this study, because it was the beginning, it was easy just to look at what is the dose-response relationship. You can see 0.25 MAC isoflurane is sufficient to confer this cardioprotection. To translate this, 0.25 MAC isoflurane means the patient is still awake, if you would actually translate that to a human being, right? This was done in dogs. And so even if you have a mild sedative effect of volatile anesthetics, you get already this cardioprotection. And the higher you move, you really get the implication that there might be something more, but not in terms of infarct size measurement. But to me, the more you have actually on board in the patient, eventually you will have a bigger effect, because from here you can already deduce that this is a threshold effect. So once you're above threshold, there's no more cardioprotection, but the threshold has to be reached, and in healthy beings, this is as low as 0.25 MAC, but the sicker the patient is, the threshold might be actually elevated, so the more you take, the more likely it is that you actually surpass this threshold. This whole research actually is able to answer one question. Whenever you do research like this, you always have a combination of ischemia and reperfusion. If you had ischemia ongoing without reperfusion, then of course you cannot study anything, so you always need reperfusion afterwards. And the question really is, and it took a long time to be actually supported in the community, that the main thing is actually reperfusion. The ischemic injury induced by ischemia, you cannot do something about it. What you really can modify is the time of onset of reperfusion. We know that nowadays, okay? But in this experiment, which I will show you here, we actually are able with volatile anesthetics to sort it out. When do volatile anesthetics work in this scenario? Do they work during preconditioning, during occlusion, during reperfusion, and the combinations of all the different kinds of treatments? And what you can see here, preconditioning is as good as delivering the volatile anesthetics after ischemia, now called post-conditioning, but it's not working through ischemia. What is interesting, if you combine pre- and post-conditioning, you don't get a bigger effect, indicating that it's basically the same mechanism underlying it, because otherwise you would see some additive effect. What's also interesting, like we just have heard, there's no tolerance. Even if you give the volatile anesthetic throughout the whole period, covering also the period where it obviously does not exert an effect during ischemic period, you still see the cardioprotective effect. Post-conditioning is also seen in all different volatile anesthetics. So basically, it's a class phenomenon of the volatile anesthetics, and as a comparator, ischemic post-conditioning is the same amount of efficacy of cardioprotection. So basically, with volatile anesthetics, we are able to have a therapeutic option after the indication of a patient who is ischemic. So that is the thing which is so interesting about volatile anesthetics. I extended these studies also to the brain, not just to the heart. And even in the brain, you can see 1 mg, 2 mg, 3 mg of sevoflurane will provide cerebral protection in a special preparation in this case. And sevoflurane, here you see better functional status of the cerebrum, and these are special antagonists indicating a mechanism here. What is also interesting, if you do it in an in vivo whole animal experiment, like in rats, which were done here in this case, where you do preconditioning, you can see here normal sham rat CA1 region of the hippocampus. Then you see here a dense layer of Purkinje cells, which actually indicates necrosis after being resuscitated. And these animals down here, C and D, they also went through CPR, but this time with preconditioning. And actually you cannot see any difference histologically from a sham-treated animal. So again, indicating you see volatile anesthetic-induced cerebral protection. How does all that experimental data actually translate into the clinics? And this is a long ongoing debate, which I think is now closed, or almost closed, is at least in the cardiac field. And a nice study done by Landoni, they did a meta-analysis actually looking through all the published data, coming up with this most important result here. Volatile anesthetic group mortality 1.3%, in the TIVA group as the comparator 2.6%. So half the mortality if you use volatile anesthetics in CABG procedures. Another study done here looking again into CABG patients, looking at complications. You can again see the mortality is on the side of the volatile anesthetics. We have seen that before. The in-hospital mortality also lower when you use volatile anesthetics. The overall mortality in the non-cardiac surgical patients is not different, so you cannot see here anything, unfortunately. But it's interesting, pulmonary complications, again, lower in the volatile anesthetics, and yet again, in non-cardiac surgical patients, pulmonary complications also lower, indicating some positive effects also in the lung. A very nice clinical study, which is very close to what we've seen in animals, is this Spanish study here, where they actually looked at regimen sevoflurane against propofol, and then continuation of either propofol or sevoflurane in the ICU. And they come up with the data of troponin I levels being always higher when there's propofol on board compared to volatile anesthetic. Again, indicating that in the clinic, really, volatile anesthetics confer cardioprotection. The ACC and ACHH colleges actually put out a very quick recommendation in 2007 indicating and recommending to use volatile anesthetics in any patient at risk for myocardial infarction to use volatile anesthetics. So if it is actually existent in cardiac patients, why shouldn't it be also protective for all patients? I don't see any reason why this should not be the case. And one study group led by Meiser actually looked exactly into that, looking into the patients on a mixed surgical ICU, retrospectively analyzing the regimen if they were actually either on volatile anesthetics or on propofol or midazolam as a comparator. Okay, the patients were not significantly different, but outcome, survival, was significantly different, indicating again, yes, even in the ICU, in the setting where you just look in the ICU, post-conditioning, so to say, isoflurane or sevoflurane versus propofol, you see a better survival rate. So to summarize all this, we have heard about control of volatile anesthetics. That's a given from the pharmacokinetic standpoint. That's a clear plus for volatile anesthetics to use in the ICU for a sedative agent. But on the other hand, we have this strong organ protection by volatile anesthetics, and I showed you only heart, brain, and lung, but it's actually been recognized in all organ systems, being liver, being the kidney, being skeletal muscle. That's a universal process where you really can say, well, volatile anesthetics induce cardioprotection, they induce organ protection in all organs studied so far. And when I should conclude, is it fact or fiction, then I can say, well, the organ protection is definitely a fact, but it's fictitious if you ask for a large randomized controlled trial comprising 10,000 of patients, because there will be no support for that kind of research. Thank you very much.
Thank you. Do we have any questions? So if not, I have a question. So it sounds like inhaled anesthetics are a panacea. They protect everything. What should we be looking out for, though? Is there reason to beyond the obvious of patients who have a history of malignant hyperthermia or something? Are there organs which may not benefit from inhaled anesthetics?
If to take the last question for the last part of your question first, basically what we do with volatile anesthetics is basically activate an inborn defense mechanism. That's what it basically breaks down to. Mm-hmm. And therefore it's in all organs. There's no organ you could think of where it will not work. What you have to be aware of course, is the side effects of volatile anesthetics, and this is really seldom, but it can happen. Malignant hyperthermia, you never know what's happening in the long run, but with millions and millions and maybe billions of patients in the meantime in anesthesia, we don't know of any really bad side effects other than that.
So thank you. I will, yes.
It all breaks down to two major points, right? And the thing is, do you really control the variables in the clinical studies, and are they powered enough? And there's no single study which is powered enough, because you need cardiological studies comprising 10,000 patients against 10,000 patients, because myocardial infarction in the clinics is a seldom event. It's only between 1% and 3%. So from that point of view, the large clinical trials is what is always asked for. Therefore, I said it's fictitious that we will ever see them. because there's no real interest by the industry to actually sponsor a large study like this. Then there's a second point. The cardioprotection is a threshold effect, and we've got opposing factors to it. So there are some medications, we have got some disease states which actually hamper this cardioprotective effect. Just to name two, it's glucose and it's beta blockers, which actually have an interference. So in order to actually explain why do some clinical studies show a positive effect, others don't, then the answer is, well, they have not a good control of all these other variants.
Yeah, I will point out that we have an ongoing observational trial with 1 million patients enrolled a year undergoing surgery, and
Fantastic.
the the remarkable safety of modern surgery has a lot to do with anesthesia, and perhaps a lot to do with the common use of inhaled anesthetics being organ protected. All right, thank you very much. So our third speaker is Professor Leur from the head of the Intensive Medicine and Reanimation Department in Brest. He'll be talking about the short and long-term effects of volatile anesthetic.
So thanks a lot for the invitation. I must also apologize, I won't be as fluent as the previous speaker. Though I'm a medical intensivist, I'm not an anesthesiologist, so that is the main reason why I won't speak about sevoflurane, but only about isoflurane. And in a previous life, I also used to be a pulmonologist, which is a second reason why I mainly use isoflurane. So I will try to answer to two brief questions at least. Why should we use volatile over IV sedation? And why should we use isoflurane over sevoflurane? So, all the anesthesiologists will tell you that you must use sevoflurane. You must use the most recent volatile agents. But we are not in the operating room. We are in the ICU. And is it really mandatory to gain 1 or 2 minutes? Yes, but why? Why should we use the most recent and so the most costly agent? Isoflurane is an ancient agent, so it costs less. That's also the main reason why I'm still using it. In the ICU, that's not a huge problem. Even with isoflurane, even if the recovery lasts a little bit longer, it will always be shorter than using the IV sedation. I don't even remember the study where I just picked this slide, but you can see that using isoflurane, you just gain 1 minute of recovery time as compared to sevoflurane. That's not a matter of interest in the ICU. So, the second reason why I use isoflurane is about bronchodilation. I'm used to be a pulmonologist, and the first time when we use isoflurane was to treat severe asthma. Severe asthma is no more a great problem in the medical ICU by now, but we still have some patients that are very difficult to treat with that. And certainly the volatile agents are the most potent bronchodilator. And in our current practice, when we are using volatile anesthetic, we do no more nebulization when the patients are receiving volatile anesthetic. So this is a short study, experimental study on dogs. Bronchoconstriction was induced using methacholine. As you can see, the respiratory resistance did increase very rapidly. You just give them a volatile agent, immediately the resistance decreases. If you increase the volatile agent concentration, you get a little bit more effect. That's in dog also, but it has been done so much time. It has been done, it's been used for so many years that you can be sure of that. This is a more recent study that was published in the British Journal of Anesthesia, just comparing isoflurane, sevoflurane, and desflurane. There is no statistically significant difference in terms of bronchoconstriction relief in between those different agents, but maybe a tendency for higher resistance using desflurane. But at least isoflurane does probably better, and it still certainly costs less. So if you are interested in bronchodilation, you should still use isoflurane. There have been several not very good studies from a scientific point of view, but there is significant experience, at least for medical intensivists, using volatile agents to treat patients with acute severe asthma. So this is one that was published later on in the respiratory care, 31 mechanically ventilated children with very severe acute asthma. As you can see, the pH was very low, the PCO2 was very high, and immediately after the introduction of the volatile agents, the patient's clinical status increased. It is well known for years. The problem 10 years ago was that we did not have devices that did enable such agents delivery before the Anaconda. And another problem, that's the reason why the scientific proof is not so good, is that in most cases, patients are not monitored quite well. If we want to use volatile agents to monitor, to treat patients with acute severe asthma or even COPD patients with acute exacerbation, we should at least monitor the resistance, the airway resistance. In fact, most actual devices, ventilatory devices, do depict us a resistance if we just have a look on the resistance. But even if you don't have that, it's a very simple thing to measure. The overall resistance, you just have to set the flow rate at 60 liters per minute, and so the resistance, the global inspiratory resistance is peak pressure minus plateau pressure, and so you get a very rapid evaluation of your overall resistance. Last week, we just admitted to our medical ICU a 60-year-old patient that had very, very old and very severe acute asthma. We just measured the resistance. It was higher than 80. So the patient's condition was very severe. She was comatose. We just intubated her. We just measured the resistance, and then we just go on volatile agents. And less than 15 to 20 minutes later, the resistance did decrease to at least 25. So the patient was extubated very rapidly, and then she get on continuous nebulization after that. So it works very fast. It's a very easy thing to do. The second question is, why should we use isoflurane as considering the hemodynamic effect? It's quite known also that potentially isoflurane should have less hemodynamic effects than other agents. We are not dealing with propofol. We all know that propofol has also a very important hemodynamic effect. We are just comparing the different volatile agents in between them. And we all know that not the studies are well performed. Those are mainly experimental studies, but we all know that the profile, the safety profile of the drug, the safety profile of the isoflurane may provide us less blood pressure decrease. It's well known for years. We have just done several, at the early years of our experience, we have just done a very short evaluation of the hemodynamic profile of our patients, just giving them isoflurane. And we, of course, observe a slight decrease in the blood pressure, but this blood pressure decrease was very slight, and it just returned to the normal values very rapidly. So that's not a problem for us in a clinical routine. Of course, we won't use isoflurane for sedating patients in very severe shock, but it can be done for most of our patients very easily. If there are any clinical data in addition to what I said that would convince you, certainly the cost. Isoflurane costs less than standard sedation, and this nowadays could be an interesting value for us. So there are numerous, so this is a French slide, so I will pass very rapidly. There are numerous of studies that can help us choose our strategy. In the previous study that we have done in 2008, we just had a focus on the potential cost effectiveness of isoflurane sedation as comparison to the other drug. We have a standardized protocol using midazolam plus some fentanyl, and we just compare it to the use of isoflurane. The first conclusion of our study was that in 2008, isoflurane sedation was very simple in the medical ICU without any experience in terms of anesthesiology, and the second conclusion was that it may be also cost effective. We observed the cost reduction, so this is a slide, the table for all of our patients. We did observe in some patients a slight decrease in terms of cost or daily cost. The first day under standard conventional IV sedation just cost almost 140 euros, and when we just switch it on to isoflurane, we just decrease to below 100. It clearly depends on the hospital where you are living. It clearly depends on the market, on what types of drug you are getting, but in most cases this could be the same. The problem is that, of course, we are using some scavenging units, some different devices. So if we are just dealing with short duration sedation, then isoflurane sedation could cost a little bit. So you have also to select your type of patient. From my point of view, isoflurane sedation should be considered only for mid-term or long-term sedation and not for very short sedation in the ICU, but it may help also. So the other thing is that if you are using isoflurane, you should standardize your sedation protocol. Once again, this is our current standard protocol in our ICU. We just standardize everything. Our first line is midazolam. We just begin at 3 milligrams per hour plus fentanyl. We just increase according to the goal. We just use Ramsay. And when we do not reach our goal, our second line is immediately isoflurane. We do not switch on to propofol as a second line. Propofol is our third line. It works well for more than 10 years. We are quite happy with that. So for the moment, we only considered isoflurane if the sedation was a failure, if we were not able to achieve our goal, but now we are going on for a first step strategy using isoflurane. But we also are using isoflurane as a first step strategy for specific patients, of course, status asthmaticus, cardiac arrest, just because of this cardioprotective effect, but also for status epilepticus, just because it's also certainly the most potent agent for that. You have seen these slides. They're also very good indication that using isoflurane on a routine basis could decrease the overall mortality of the patients. This was also depicted priorly. So I will pass rapidly on that. In the meta-analysis by Angela Card, also we just observed the same. It seems that when we compare volatile agents to standard IV sedations, you can get impact in terms of time to extubation. So this is also true if you are just comparing isoflurane sedation to propofol itself. There's also that study by Kranik that just also helps us to show that just because we are certainly improving the sedation, we are also decreasing the time under mechanical ventilation and thus increasing the 3 days of mechanical ventilation, so another potential major clinical impact. So I would just go on just to finish on the very short off-label indication. Status epilepticus. If you have a refractory status epilepticus, isoflurane sedation is a very, very powerful agent. You can see in this slide, this is just a clinical case, but it's a very illustrative clinical case. On the A, the patient was under status epilepticus. He just received lorazepam without any effect. It just went on isoflurane sedation, and immediately he was burst sedated. So it works very well, and it works very rapidly. And we are now ongoing on a very, very off-label study. The off-label study is on the pre-hospital care. As you know, the pre-hospital care is a very tricky thing to do. You have to sedate very heavily your patient, just because most of the time you have very low quality emergency and transport ventilator, and the current practice is just to very heavily sedate your patient. So they have a lot of adverse events just using the standard IV sedation. And we are just trying to have a look if it will add something. And the first patient, the first conclusion of the emergency physician, the study is just ongoing. It's just a pilot study, is that it works well. It works very, very rapidly, much more rapidly than any IV sedation. So it could be of interest, even for very short transport duration. So in conclusion, isoflurane sedation is very cost effective. That's quite clear. As compared to midazolam or propofol, but certainly as compared to sevoflurane also. The question is, could it be also cost effective as compared to dexmedetomidine? I'm quite convinced also. Just dexmedetomidine is a very, very expensive drug. The question is that, does the potential interest of the dexmedetomidine drug can be balanced with the clear cost effectiveness of isoflurane? I'm also totally convinced of that, but we need more study on that. It's quite clear also that isoflurane is the most potent bronchodilator, so it's one major reason to use it in the medical ICU. We have seen from both speakers that we observe very few adverse events, even after more than 15 years of use, and we are quite convinced that we should get additional benefits from the use of these volatile agents in our current practice. Thank you.
Thank you very much. Are there any questions? Okay. Oh, there we go. Dr. Knafi.
No, honestly, for the moment, the pre-hospital care study is just a pilot study. We just and inside the hospital, we just switch it on to propofol. Honestly, just because we don't want to carry on the scavenging unit, and the problem is that in the CT scan, nurses will be a little bit afraid of these types of devices, but we could do so.
We have a question there.
My question is, how effective is this scavenging system? I'm not familiar with the ICU sedation, but we have been measuring occupation and exposure during the inhalation and anesthesia in the operating theaters. And obviously there is a certain source of evaporation from the mouth of the patient alongside and the trachea tube. So I don't know whether someone knows anything about evaporated amount through the mouth in the intensive care setting.
This issue have been monitored by Peter Sake in one of his previous study. The anaconda by itself just scavenge almost 90% of the gases, and the other 10% are scavenged by our charcoal filter. And the pollution, the external pollution, is very low. Yeah. And I have some more answer. In the ICU, we always monitor the pressure inside the cuff. So we decrease a lot the leaks. And in the study by Peter Sake, he just proved us that the environmental pollution was very low and quite null. Yeah, there should be some pollution, but very, very low. We also use some closed-suction system, and it was monitored in the ICU room by Peter Sake, just doing some with specific.
Operating theater, this is the 1.2 ppm
Yeah.
during your
Mm.
So, Professor Kale, did you have something to add to this?
I can give you also an answer. This is why I asked about transportation. We go on transport always with the, if this patient is volatile, 90% or 90% of the patients are volatile. We simply go to the transport, and if the patient is difficult to manage, we go the ICU ventilator with the scavenger system, otherwise not. We were measuring along the way with the CT scan, and then within the CT suite, we're measuring the concentration, and we could not detect any. When we were measuring within half a meter away from the patient, we were getting 1 or 0 ppms. So we also needed to do the occupation hazard study, and it's not a problem within the ICU, also in the CT suite.
Okay. So I would like to encourage people who are interested in this afternoon. There's an excellent session on sedation that will include a number of lectures on inhaled anesthetics in the ICU for people who'd like to get more information. The Sedana also has a booth in the display area that is open and available for more information. So with that, I'd like to thank our three speakers and conclude the session. Thank you very much.